Metastatic pancreatic adenocarcinoma manifesting as otomastoiditis and Collet-Sicard syndrome. Otomastoiditis is not common in adult populations. When adults are diagnosed with otomastoiditis, uncontrolled diabetes and impaired immune system functioning are the typical factors suspected of predisposing them to this disease process more commonly seen in children. Malignancy has been shown to be prevalent among adults diagnosed with mastoiditis. However, is usually not suspected until patients develop refractory otomastoiditis and associated complications. This delay in diagnosis may contribute to increased morbidity and limit potential treatment options of the insidious malignant process. We report a 61-year-old male with no reported medical history who presented with 3 months of neck discomfort, dysphagia, and significant unintentional weight loss. Upon exam, left-sided otitis media was diagnosed otoscopically, and MRI revealed extensive left otomastoiditis with an adjacent phlegmon, left skull base osteomyelitis, sigmoid sinus thrombosis, and involvement of the left jugular foramen and hypoglossal canal. The patient was started on broad-spectrum IV antibiotics. Next-generation sequencing would later reveal elevated levels of Pseudomonas aeruginosa, which is a well-described pathogen for malignant otitis externa and would fit clinically. He would complete a 6-week course of Cefepime after discharge. Unfortunately, the patient was readmitted 3 weeks later for management of his dysphagia and refractory otomastoiditis, as evidenced on repeat MRI, for which TPN and meropenem were started, respectively. He then required endotracheal intubation due to altered mental status and concern for inability to maintain his airway patency. While the patient was intubated in the intensive care unit, ENT performed a laryngotomy. Immediately after extubation, the patient developed a persistent complete peripheral left-sided facial palsy with forehead involvement and left tongue deviation. A head CT was performed to rule out ischemia, which it did. At this juncture, given no radiologic improvement of the otomastoiditis after completing a 10-day course of meropenem, either a resistant organism or underlying malignancy with cranial nerve involvement became the leading differential. A discussion with ENT led to a decision to obtain a tissue sample. The patient then underwent a complete mastoidectomy. Surgical pathology of the mastoid bone revealed focal high-grade adenocarcinoma with an infiltrative pattern with single cells and necrosis. Imaging for staging would reveal multiple liver lesions and a mass in the pancreas with liver biopsy showing adenocarcinoma, consistent with the pancreas as being the primary malignancy. The patient is currently undergoing palliative radiation therapy as he was unfortunately not a candidate for systemic therapy due to his ECOG performance scale score. Discussion. The uniqueness of this case was the atypical way in which pancreatic cancer presented symptomatically via a metastatic lesion to the temporal bone, causing otomastoiditis. Pancreatic adenocarcinomas do not commonly metastasize to the temporal bone. In fact, pancreatic adenocarcinomas do not commonly exhibit skeletal metastasis at all, usually spreading more locally to regional lymph nodes, the liver, and other organs within the peritoneum. The incidence of skeletal metastasis of pancreatic adenocarcinoma was estimated by one systematic review based on radiographic and autopsy results to be between 5 and 20%. Among skeletal metastatic sites, the spine is the most common site. The most common metastatic temporal bone lesions occur in the petrous aspects of the internal auditory canal and mastoid air cells and can manifest as chronic suppurative otitis media, mastoiditis, and in some patients, palsies of the glossopharyngeal, vagus, accessory, and hypoglossal cranial nerves. The constellation of symptoms that result from the unilateral palsy of these lower cranial nerves, like dysphagia, dysphonia, impaired taste, has colloquially been termed as Collet-Sicard syndrome, for which metastasis has been found to be the most common cause. In conclusion, this case demonstrates how healthcare providers should be highly suspicious of malignancy when non-diabetic, immunocompetent adults present with new-onset otomastoiditis or chronic otologic infections, especially when cranial nerves are afflicted. Earlier recognition of these insidious malignant processes may improve outcomes in terms of candidacy for aggressive surgical, radiologic, or chemotherapeutic interventions.